Welcome guys, in this video we are going to discuss about the Neet-Ss medicine recall paper based on the gastroenterology question. Coming to the first question, it asked about the Schilling test. Now Schilling test is very much common to be asked in the exam. It has been asked in FMG, asked in NEET PG as well as has been asked in Neet-Ss this time. Now what is Schilling test? It is the method of identification of pathogenesis behind the B12 deficiency. So, it is the method to identification pathogenesis behind vitamin B12 deficiency. Alright. So, what is employed in this test? Radio labeled B12 is given to the patient who are deficient in B12 and urine sample is collected for 24 hours and this radio level B12 is measured in the urine. Now, if in the urine sample more than 10% value comes, what does it signifies? It signifies that there was decrease in B12 in the body due to the decrease in nutritional supply which led to the B12 deficiency, and when we supplied from outside, this was replenished and enough amount was excreted in the urine. So, more than 10% if it is detected, it means the etiology was nutritional deficiency. Alright, okay. Now, when the value in the urine comes less than 10%, here we need to apply the step 2. This was a step 1. We need to step 2 of Schilling test. What is the step 2 of Schilling test? Step 2 of Schilling test, here we give along with B12 which is radio labeled, we give intrinsic factor to the patient, and similar 24-hour urine value is corrected and B12 is measured in the urine, radio level B12%, and if it is detected more than 10% in the urine now, when it was earlier less than 10%, it means with addition of intrinsic factor deficiency has been supplemented. That means there was intrinsic factor deficiency, that is if it is less than more than 10% now, it means it is a case of pernicious anemia or deficiency of intrinsic factor. Alright. Now, if in the also the step 2 of Schilling test, if it comes less than 10%, we apply the step 3. In step 3, what is done? In step 3, patient is given 3-week antibiotic course. After the 3-week antibiotic course, patient is again gone for the same test, that is similar to the step 1. Radio level B12 is given and it is measured in radio level B12 is given and measured in the urine. Now, if it improves, that is more than 10% comes here, more than 10% here, it means there was small intestinal bacterial overgrowth which recovered with antibiotic course and the patient recovered and B12 deficiency was recovered. Alright. Now, again if it comes less than 10%, we need to look for the other etiologies. So, what are the other etiologies apart from no nutritional deficiency or pernicious anemia or small intestinal bacterial overgrowth? We need to look at for the etiologies for pancreatic insufficiency as well as the malabsorption syndrome. Okay. So, this is the basic of Schilling test which help to identify the etiology behind the B12 deficiency. Now, if you look at the question, it says when it is normal, that is we know already small intestinal bacterial overgrowth, it is abnormal. So, obviously, this is not the answer. Now, what happens in gastric bypass? Gastric bypass is an operation in which part of the stomach is taken away. So, as the part of the stomach is taken away, stomach contains parietal cell. Amount of parietal cell will also decrease. Parietal cell is responsible for secretion of intrinsic factor as well as HCl. Now, as intrinsic factor and HCl will be below par in gastric bypass patient, due to this deficiency of intrinsic factor, it will lead to deficiency of vitamin B12 and abnormal Schilling test. So, obviously this is also not the answer. Now, coming to the Crohn's disease and celiac disease, what is the most common site involved in Crohn's? Most common site involved in Crohn's is the ileum, alright, and celiac, pathology behind celiac is the presentation behind celiac is the malabsorption features. Okay. So, the site of absorption of micronutrient for duodenum, jejunum and ileum are, for duodenum it is iron, for jejunum it is folic acid, and for ileum it is vitamin B12. Now, in Crohn's disease, ileum is the part which is the most commonly affected, around 75% cases. So, as the ileum is involved, obviously B12 absorption will be hampered in case of Crohn's disease. Therefore, in Crohn's disease also Schilling test will be abnormal. So, normal or near normal Schilling test can be seen in case of celiac disease. Okay, all right. Now, let us move into the next question. Now, before moving to the next question, this Schilling test is practically not done in any place, right? This is only for the exam purpose, favorite question for the examiners, but in practical, to find the etiology, do we ever do Schilling test? No, we do not do Schilling test. Why we do not go for Schilling test? Because the radio level B12 which is required for this test is bovine in origin and very costly and not available readily everywhere. And also the procedure is very much cumbersome. You need to collect the urine for 24 hours, measure the B12 level. If step 1 is not cleared, you need to go to the step 2. If step 2 is not cleared, you need to go to the step 3. So, what we do is basically we bypass the Schilling test and go for other method to find the cause behind the etiology of B12. Even if you look the Harrison, it also mentioned clearly radioactive B12 is no longer available and Schilling tests are no longer performed in routine practice. So, what are the other methods applied? Now, if we can check Schilling test, what is basically it is helping us? It is helping us to identify is the etiology is pernicious anemia or not, or whether the etiology is small intestinal bacterial overgrowth or pancreatic insufficiency and malabsorption. Alright, these are the etiology which the Schilling test help us to identify between the B12 deficiency. Now, for pernicious anemia, you know it is the due to deficiency of intrinsic factor, and where is the intrinsic factor get secreted from? It is secreted from the parietal cell. Parietal cell also secretes HCl. So, invariably in case of pernicious anemia, HCl will be low. So, if HCl will be low, patient will have features of atrophic gastritis. Alright. So, atrophic gastritis in a otherwise normal individual who as well as presented with vitamin B12 deficiency strongly suggests towards the etiology to be pernicious anemia. This becomes one of the indirect marker to identify pernicious anemia. Alright. Small intestinal bacterial overgrowth can be diagnosed by gastric aspirate and its following culture. Pancreatic insufficiency, we have indirect marker as well as direct marker in the form of secretin stimulation stage, or indirect marker measuring fecal elastase level or fecal chymotrypsinase level. Malabsorption can be identified by 24-hour fecal fat and typical sign and symptom of malabsorption. Alright. Okay. Now, you can see here upper GI endoscopy imaging shows the atrophied mucosa which is seen in atrophic gastritis, a feature of pernicious anemia. Alright. Okay. Now, coming to the next question, what does it say? It says elderly geriatric male patient with diabetes presented with complaint of epigastric pain and dyspepsia. It was for the past 3 weeks and he is on Naproxen 500 mg twice a day for the management of rheumatoid arthritis. Alright. Okay. On abdominal examination, epigastric tenderness was present, the most likely cause. So, basically they are asking about a old man who is non-diabetic, non-rheumatoid arthritis, who presented with epigastric tenderness. So, an epigastric tenderness is present for last, epigastric region tenderness is present for last 3 weeks. Okay. So, what are the differential diagnoses for epigastric tenderness? This can be divided into like GI causes. GI causes can be gastritis, it can be esophagitis as well as peptic ulcer disease. It can be due to cardiac causes. What are the cardiac causes which can mimic the epigastric pain? Obviously, the most common ones the SES as well as MI. Sometimes pericarditis can mimic as epigastric region tenderness. It can be due to biliary causes like biliary colic, cholecystitis or cholangitis. It can be due to pancreatitis as well as vascular causes like abdominal aortic artery aneurysm rupture or mesenteric ischemia. Mesenteric ischemia usually presented with band-like sensation and hemodynamic instability. Alright. Now, if you look at the case itself and the option, this is very much easily identified. Alright. Patient was on Naproxen for last 3 weeks and epigastric tenderness. It suggests etiology towards to be peptic ulcer. Even if you look what Sleissenger mentioned second most common cause of duodenal as well as gastric. You can see from the pie chart itself, most common causes H. pylori infection and second most common causes NSAIDs. Alright. Okay. Now, risk factor for NSAID ulcer involved like complicated ulcer, use of multiple NSAID, use of high dose NSAID or anticoagulant or an uncomplicated ulcer, age more than 70, H. pylori infection, use of glucocorticoid. In your patient, the patient was geriatric in age group, there is high dose of NSAID was used as well as it was going towards rheumatoid arthritis. That means rheumatoid arthritis which required NSAID, obviously the patient would be on glucocorticoid therapy. So, there is cumulative high risk for NSAID ulcer. Okay. So, obviously the answer is here peptic ulcer secondary to NSAIDs. Now, coming to the third question from the recall series. So, what does it say? It says there is a 45-year-old female, BMI 34 kg per meter square. So, what does this BMI 34 kg per meter square signifies? Now, what is the normal BMI? Normal BMI is 18.5 to 22.5 for South Asian population, and 22.5 above is considered as overweight and less than 18.5 is considered as underweight. More than 27 is obese. So, this female who is 45-year-old is obese, maybe morbidly obese even. Alright. So, female 45-year-old obese patient presented with right upper quadrant pain and she is also known case of polycystic ovarian syndrome. Okay. So, polycystic ovarian syndrome, 40-year-old female, right upper quadrant pain, mildly deranged ALT and AST and hypertriglyceridemia. So, ALT, AST mild change and increased triglyceride level, female 45 years. Alright. Even liver biopsy was not even mentioned. With this known risk factor, the disease can be easily identified what they are asking about. Alright. So, as the liver biopsy has been given, let us just zoom into the picture and see what has been shown here. So, you can observe here clearly there are vacuolated cell. What are these vacuolated cell signify? These are nothing but fat cell or steatosis. Now, if you look properly, we will find there are accumulation. Alright, there are accumulation of multiple nucleated cell. What does it signify? It signifies there is ongoing inflammation process. These are inflammatory cells, mainly PMN polymorphonuclear neutrophils are present here, inflammatory cell, and if we look here, there are ballooning degeneration also present. So, ballooning inflammatory cell as well as fat cell, what is the etiology going at? This is non-alcoholic steatohepatitis. Alright. As well as if you see the risk factor what has been mentioned here, everything is going towards, that is obesity, PCOS, female, mild ALT, AST range, increase in triglyceride level, everything goes toward NASH. Now, coming to all the rest of the other option what has been mentioned here. So, if you look at the each and every one slide, histopathological slide. Now, what is this slide signified? You know, this is liver cell 1, What are the abnormal cell you can identify? Abnormal cell, what you can see here, like there are lot of black colored cell. Now black colored cell or increased pigmentation in liver cell is usually seen in only two cases, alright, usually seen in two cases. One, there is accumulation of iron, or either there is accumulation of end product of epinephrine metabolism end product accumulation. Now what is the disease known as in where there is iron accumulation? Disease which is known as iron accumulation is hemochromatosis, and disease in which epinephrine gets accumulated is known as Dubin-Johnson syndrome. Okay. Now if you look properly, as well as along with iron accumulation, there is increase in the number of cellularity, which is also suggest toward fibrosis, alright, fibrosis. Now next, this is a cut section. First one is gross imaging. In the gross imaging, you can see partial resection of liver has been done with a cut surface area, this grayish cut surface area containing hemorrhagic focus, alright, hemorrhagic focus. Now if you see this photomicrograph, it contains lot of fetal cell, fetal origin cell, alright, fetal origin cell, minimal mitotic activity is present. This is a embryonal type, of liver cell. And if you look at this one, this is particularly different from all other, it almost look like the specimen of kidney known as the nephroblastoma stage of the liver cell. This nephroblastoma stage of the liver cell means that the teratoid hepatoblastoma stage, alright, okay, hepatoblastoma stage. In this lower diagram, you can see lot of alveoli is present as well as liver cell in between, So this is nothing but a metastasis of liver malignancy to the lung, base of the lung metastasis. And in this diagram shows post treatment picture. How do I know post chemotherapy or post radiotherapy picture? Because there are lot of hemorrhage in between, and as well as there is cells which are improving. Okay. So these are the different stages and patterns of the hepatoblastoma. Now, in case of drug induced liver injury, different pattern of injury based on the drug used can be seen in histopathological examination. For example, cholestatic pattern is seen in amoxiclav, amoxicillin clavulanic acid. In isoniazid, which is very commonly asked, acute hepatitis pattern is seen. In paracetamol, there is necrosis. With use of steroid, there is bland cholestasis, and that is the anabolic steroid, whereas in glucocorticoid or tamoxifen result into similar picture of non-alcoholic fatty liver, which I have just discussed, as well as nodular regenerative hyperplasia is seen in azathioprine. Alright, these are the important drug induced liver injury phenotypes. Okay. Now this is obviously a normal liver cell. Okay. So coming to the next question. Okay. So what does it says? It says a 33-year-old female patient who presented with the complaints of anorexia, abdominal pain, low stool and weight loss. Okay. So if you look at the presentation here, so there is relatively young age female who is presenting with decreased appetite, as well as abdominal pain, low stool and weight loss. On abdominal examination, right lower quadrant tenderness was present. So where was the tenderness localized here? Tenderness was localized in the right lower quadrant this time. So what are the thing that can be thought immediately if we think right lower quadrant pain? The thing that should immediately come to your mind is, one, whether it is appendicitis or not, and other ileocecal region condition. What are the other ileocecal region condition you need to think about? Other ileocecal condition can be ileocecal TB, tuberculosis, as well as Crohn's disease. These are the usual pathology that should come in your mind. Even it can be, so if you look at the options, Crohn's disease has been mentioned, ileocecal TB is mentioned, celiac disease no, celiac is not, means Crohn's TB is mentioned. Okay, all right. Now, can it be seen in ulcerative colitis? Yes, in case of backwater ileitis can have similar presentation. So, what is the next step? Next step, an ileocolonoscopy was done. Before that, obviously you need to do ultrasound examination to rule out obvious pathology like appendicitis or CT abdomen can be done. So, ileocolonoscopy was performed and biopsy showed infiltrate extending beyond the mucosa into the submucosa and muscularis with crypt hyperplasia and crypt abscess. Now, crypt abscess is pathognomic feature of ulcerative colitis, alright, but it should be always kept in mind crypt abscess can also be seen in Crohn's disease. What is not seen in ulcerative colitis is the part written just next to it is a skip lesion. Skip lesion is very much specific to Crohn's disease, not seen in ulcerative colitis. Therefore, most likely diagnosis here is obviously the Crohn's disease. Okay, all right. So, this is the table from Sleissenger, which again it is difference between Crohn's colitis and ulcerative colitis. So, if you take Crohn's colitis mucosal, submucosal and transmural environment, mucosal transmural involvement, but it is in the later stage in the fulminant disease. In histopathology, granuloma is seen, and granuloma is usually absent in ulcerative colitis. All right, and crypt abscess may be present. This is the most important line here. And crypt abscess and ulcer are the defining lesion of ulcerative colitis, but that does not mean that it cannot be seen in Crohn's colitis. It can be seen in Crohn's colitis as well as. Ileum is the most common involved region in more than 75% of cases, whereas it is rarely involved in ulcerative colitis. I have just discussed now because of the involvement of ileum there is betel deficiency in Crohn's disease. As well as if you look other feature what are the important like epthi, late disease, stellate, rake, beer claw, linear, serpentious ulcer and cobblestoning can be seen in mucosal cell lesion in Crohn's disease. All right. Okay. So again, this is the endoscopic image of Crohn's and as well as ulcerative colitis. So, crypt abscess, crypt lesion, these things are features of ulcerative colitis, whereas granuloma formation are histopathological features of the Crohn's disease. All right. Okay. So, here you can see pseudopolyp in ulcerative colitis, which is absent, usually absent in case of the Crohn's disease. All right. Okay. And there again you can see a granuloma. Granuloma is very specific for Crohn's disease, but it can be seen in ulcerative colitis too. Okay. Now, moving to the next question. Okay. It says about the which of the following is the first test to be done in Zollinger-Ellison syndrome. All right. Okay. So, what is the Zollinger-Ellison syndrome? Zollinger-Ellison syndrome is the condition characterized by increase in gastrin secretion. All right. Now, what happens when there is increased gastric secretion? This increase in the gastric secretion activates the parietal cell as well as enterochromaffin cell. Remember, this enterochromaffin cell, not enterochromaffin like cell. All right. So, what happens when there is activation of parietal cell or enterochromaffin cell? There is obviously what is the function of parietal we have just discussed before. Parietal causes increased secretion of ACL as well as intrinsic factors. So, there will be increase in ACL, increasing intrinsic factor secretion. All right. So, pathogenesis is due to the increase in ACL secretion. It will lead to formation of multiple peptic ulcer, and usually this multiple peptic ulcer are seen in unusual location. All right. It is seen in a places where it should not be. For example, it can be seen in the jejunum as well as these are refractory treatment. Now, this increased gastric secretion is related to most usually is related to pancreatic or duodenal malignancy. Okay. So, if you look at the triad of Zollinger-Ellison syndrome, these are pancreatic and duodenal tumor, gastric hypersecretion, gastric which is stimulatory and trophic effect on parietal cell and enterochromaffin cell, and the peptic ulcer. All right. These peptic ulcer are multiple and refractory medical treatment, and these ulcer are usually present in unusual location. Now, what is the function of enterochromaffin cell? Let's just discuss here. It secretes usually ANP adrenomedullin, alright, ANP adrenomedullin. Okay. So, what will happen when there is increased secretion? There will be multiple peptic ulcer in multiple places. Now, coming to the question, it says what is the first test to be done in Zollinger-Ellison syndrome? Now, when you suspect there is Zollinger-Ellison syndrome, first test you need to do is to check for the serum gastrin level. It is to check the serum gastrin level, and if it is more than 1000, that is highly specific for diagnosis of Zollinger-Ellison syndrome. Alright. Okay. So, if you check the chart, so if you suspect, when you suspect, obviously there is severe ulcer, multiple ulcer, not refractory to treatment, and there is absence of typical risk factor. I have just shown you the chart which showed the usual risk factor of the peptic ulcer. Most common was H. pylori, second most common was NSAID. So, if person is not taking NSAID, as there is no risk factor for H. pylori, or the H. pylori irrigation therapy has already been tried, in such cases you can consider to check for serum gastrin level. If the person has severe GERD, severe reflux esophagitis, and or the first presentation was the complication of peptic ulcer like perforation, or the person is suffering from multiple endocrine neoplasia type 1, or there is family history of ulcer. In such cases, you can suspect it to be Zollinger-Ellison and go for checking for specific test. Specific test, what is the specific test? It is for serum gastrin level and to also confirm that gastric pH that is acidic, that is less than 2, and if it is more than 1000, this is diagnosis is confirmed. Alright. Okay. So, this is what is mentioned in Harrison also. It also mentions to check for the serum gastrin level. First, serum gastrin level in case of Zollinger-Ellison system. Alright. Biochemical measurement of gastrin and acid secretion in patients suspect of having gas play an important role establishing this rare diagnosis. Okay. So, when to obtain a fasting serum gastrin level? Obviously, multiple ulcer which is an unusual location like jejunum with severe esophagitis, when there is no stigmata of NSAID use or H. pylori infection, there is unexplained diarrhea or steatorrhea, family history of similar presentation, family history of MEN1, and family history of peptic ulcer disease. These are the indication to obtain for suspecting to Zollinger-Ellison and obtaining serum gastrin level. Alright. So, coming back to the question, it says which of the following is the first test to be done in Zollinger-Ellison? Obviously, fasting serum gastrin level is the answer here. Okay. Now, coming to the next question. Okay. So, this is from the basic physiology part. Given below are the pair of GI cells and their secretion, pick out the incorrectly matched pair. Okay. So, chief cell, pepsinogen, we have already discussed parietal cell, intrinsic factor, these two are true. Alright. Now, D cell secretes somatostatin, this is also true. Now, the confusion here was created by EC cell. EC cell does not secrete histamine. What is the cell which is responsible for secretion of histamine in the stomach? Histamine is secreted by enterochromaffin like cell, not the enterochromaffin cell. So, what is secreted by enterochromaffin like cell? It secretes histamine as well as PTH like hormone. Alright, PTH like hormone. Whereas enterochromaffin cell is responsible for secretion for atrial natriuretic peptide, serotonin, and adrenomedullin. Alright. Okay. So, obviously, option B is wrong here. Now, coming to this question, it says a 45-year-old female non-diabetic presented with complaint of fever, right upper quadrant pain and vomiting. Her USG abdomen feature is shown below. The most likely diagnosis is. Okay, so, what is the presentation here? Presentation is fever, right upper quadrant pain as well as vomiting. alright. So, instead of vomiting, if they had mentioned jaundice, it would have turned into a triad which can be even the differential of this condition even. So, this triad is known as Charcot stats in cholangitis. But coming to this point again, fever, right quadrant pain and vomiting, what are the differential diagnosis of right upper quadrant pain if I ask? Again, let us just divide based on the structure available to us. Structure available is gallbladder, liver, as well as the lower lobe of liver, lung. So, from this structure you can tell me the pathology which is related to the right upper quadrant pain. Liver, hepatic abscess as well as hepatitis can present in right upper quadrant pain. Gallbladder, acute cholecystitis, chronic cholecystitis or cholangitis can present likewise. Cholecystitis and cholangitis can present likewise, as well as lower lobe pneumonia can present with right upper quadrant pain. Now, with the differential diagnosis, pain, fever and vomiting, now there is no history of jaundice, cholangitis is easily ruled out. Hepatic abscess and hepatitis will have other features also associated with hepatitis will have jaundice, hepatic abscess might have jaundice, and lower lobe pneumonia will have the complaint of breathlessness, cough, etc., which is absent here. So, it is almost going towards cholecystitis. Still ultrasound imaging was shown. So, if we zoom into the ultrasound imaging, we can see there is. So, what is ultrasound actually? Ultrasound is echo imaging based on the principle of sound waves. So, probe is usually kept here and image based on a reflection of the sound it produces. So, if there is gallstone, it causes hypoechoic, that is more whitish lesion, and if there is ear present, this is hyperechoic lesions. All right. Okay. That is more blackening seen if there is ear present, and if there is solid structure present, it will be more whitish in nature. And shadow just beneath the gallstone can be seen. Post-acoustic shadow will be seen just beneath the gallbladder part. This is the feature of the gallstone. So, obviously, this answer is going to the gallstone. Okay. So, coming to the feature. So, you can see this is the bile which is mainly watery. So, that is why black in color. That is the liver margin as well as their feature like sludge gallstone followed by acoustic shadow is seen. All right. Okay. So, how to differentiate between polyp versus gallstone in USG imaging? Polyp is usually rounded globular with full surface can be seen, whereas in gallstone is irregular in margin as well as can be seen along with sludge material. Polyp, in case of polyp, post-acoustic shadow will be absent, which is present in case of gallstone. All right. Okay. So, what is this picture showing? This picture is showing to us a large posterior dense shadow. All right. So, this large posterior dense shadow is suggestive of porcelain GB. All right. And there is thickening of the anterior margin present. Now, this is a close differential diagnosis of, because this is suggestive of ear like feature, this is a close differential diagnosis of emphysematous gallbladder based on USG imaging. All right. Clinical finding and presentation helps you to rule out in such cases. Now, this is a large irregular margin of gallbladder and large mass is seen, this is most likely a case of a cholangiocarcinoma. Alright, most likely you cannot obviously confirm based on ultrasound finding in such cases. So, these are the all images that was been asked in this exam. Now, coming to the next question. So, obviously this is a spotter type question, even if you do not know this is a, read the question, you know this is a case of Wilson's disease. Alright. So, what is they are asking about? They are asking about a 28-year-old man who presented with complaints of yellowish discoloration of skin. On examination there was jaundice, hepatosplenomegaly and ascites. So, this is almost like a end stage liver disease presentation. The presentation was swollen liver as well as ascites development, that is chronic liver disease has already progressed to the portal hypertension stage, which lead to the development of ascites in this patient, and ocular examination is shown below. So, which of the following is the first investigation to be done? Now, is ocular examination enough to diagnose Wilson's disease? No, this is not enough to diagnose Wilson's disease. What we need to do to diagnose Wilson is a scoring system known as the Leipzig scoring system. So, what is this scoring system all about? It consists of the clinical criteria in the form of Kaiser-Pfeffer ring or neurological symptom or MRI finding, and laboratory changes in the form of serum ceruloplasmin level or 24-hour urinary copper or lab suggestive of COM negative hemolytic anemia, biopsy which are of total liver, copper liver in case of liver biopsy, genetic study, and we need to do the total scoring. Total scoring, if it is more than 4, it is diagnosed, and less than 2, it is unlikely. Alright. Now, in this patient, what are the positive finding we already given? Kaiser-Pfeffer ring is already given. Nothing is mentioned about neurological abnormality. So, we can consider this to be normal, and no MRI imaging was also not done in such cases. Okay. So, what is the next step? Next step is something that you will do that will help you to identify the patients or help you to narrow down to the diagnosis of Wilson quickly. So, among the tests available for us, genetic mutation is rarely done and not available in all the places. It will take lot of time. Liver biopsy is also a cumbersome procedure. It is obviously the best diagnostic, rather it is a help to rule out the diagnosis of Wilson's disease instead of diagnosing, and but it will take time. Preparation of slide, preparation of patient, everything will take time. Among these three options of serum ceruloplasmin level, 24-hour urine copper and COM negative hemolytic anemia, 24-hour urine copper will require 24-hour collection, obviously it is time taking. We have narrowed down into two options of serum ceruloplasmin and COM negative hemolytic anemia. Now, if we see, we have already got 2 points from Kaiser-Pfeffer ring. We need more 2 points. Even if we can prove COM negative hemolytic anemia based on the blood report, it will give only 1 score. So, it does not have any positive value for diagnosis of Wilson's disease. You need minimum 2 values for diagnosing. So, best is in such cases serum ceruloplasmin level. Now, serum copper, serum ceruloplasmin, liver biopsy, urinary copper, obviously serum ceruloplasmin. Can liver biopsy help us to diagnosis? Obviously, liver biopsy can also help us. Can urinary copper excretion help us? Obviously, it can also be help us. So, if the question was what not to be done, answer is serum copper. This is more of a NEET PG question, and in Neet-Ss it has been asked what should be done. We should do which will help us to early diagnosis. Here serum ceruloplasmin will help us to early diagnosis. Rest 2 can also help us to diagnose though. But if MRI was mentioned in option, MRI will be the earliest thing to be done to rule out or help out to diagnose the Wilson's. Alright, okay. In such clinical scenario. Now, coming to next question. Now, this is a bit of trickier one and perhaps one of the harder question of this paper. So, it says a 25-year-old male who presented with history of bowel resection 2 years ago, presented in state of severe cachexia and is on dependency of total parenteral nutrition and multiple nutritional deficiencies. Diagnosis of short bowel syndrome was made. Which of the following type of intestinal failure is seen in this case? Okay. So, what is intestinal failure actually? So, intestinal failure is the condition when there is decreased absorption of macronutrient water as well as electrolyte. Now, how much decrease of macronutrient water electrolyte? So, that much which is enough, and we need to supplement the patient with total parenteral nutrition. So, this is the definition of intestinal failure. This is given by ESAPN guidelines. They have classified show intestinal failure based on the functional classification, pathophysiological classification as well as clinical classification. Now, this is given in the ESPN classification mentioned in the best practice and research clinical gastroenterology textbook. So, definition of intestinal failure and the short bowel syndrome. These are mainly three types. These are three definitions: functional, pathophysiological as well as clinical. Function, and main part is that functional will be decrease in absorption of macronutrient as well as water and electrolyte, which requires total parenteral nutrition supplement to the patient. Now, this functional is divided into type 1, type 2 and type 3. All right. Now, type 1 means which is acute in onset. Usually progression is days to week. So, acute conditions, and these are short term and usually self limiting condition. All right. For example, post abdominal surgery, if someone presented with ileus and requiring total parenteral nutrition support is a case of type 1 intestinal failure. Now, what is type 3 intestinal failure? Type 3 is more of a chronic condition like 3 months, 4 months, 5 months or 6 months, which require a prolonged support in the form of total parenteral nutrition. Even the patient needs TPN in home long term total parenteral nutrition support. It can be seen in Crohn's disease, intestinal obstruction, trauma, fistula, radiation enteritis as a cases. All right. Now, if type 3 patient who need prolonged support become metabolically unstable, or any condition who are metabolically unstable, and instead of acute requirement is requiring little bit of prolonged therapy of TPN, that is if they are metabolically unstable, and requiring prolonged, then the normal acute phase is considered as type 2. Okay. So, with this classification pattern, the diagnosis of the condition is not at all important to identify whether it is type 1, type 2, type 3. How is the functional status? It is important. So, if you look at this question, what does it say? It says that this male 25-year-old had history of bowel resection 2 years ago and is currently dependent on total parenteral nutrition and multiple nutritional deficiency. Is he metabolically unstable? Such thing has never been mentioned here, and so this is not going towards type 2. This is a type 3 because of the chronic duration. Had it been for only 1 or 2 weeks, had been improved on its own, it will be going towards type 1. All right. So, what are the other classification? Beside this classification, this ESPN guideline has mentioned about pathophysiological classification also. In pathophysiological classification, they have said about condition that causes intestinal failure, for example, short bowel, which is the most common cause, as well as intestinal fistula, dysmotility, any sort of mechanical obstruction which is not leading absorption of macronutrients. Okay. So, these are the causes of pathophysiological causes of short bowel syndrome. Again, they has mentioned the clinical classification. This clinical classification mentions in the criteria is based on the energy supplementation as well as the volume requirement. Based on the energy supplementation per kg body weight, whether it is 0, 1 to 10, 10 to 20 or more than 20, it is classified as A, B, C, D. And based on the volume of IV supplementation, if it is less than 1 liter, it is considered to be 1 liter, that is 1000 ml, it is 1. If 1000 to 2000 ml is requirement of supplementation, then it is considered as 2, 2000 to 3000 is 3, and more than 3000 is considered as 4. Both codes are used to classify clinically this intestinal failure. Okay. Now moving to the next question. So here it says a 80-year-old male presented with complaint of recurrent episode of jaundice in the past few weeks. So we have a presentation of jaundice. He also complains of dark yellow urine and brown colored stool. Lab finding revealed conjugated hyperbilirubinemia. So basically this question is about conjugated hyperbilirubinemia, and liver biopsy was done that showed the following feature. The most likely diagnosis is. Now if you look at the option, and you know the conditions like conjugated hyperbilirubinemia and unconjugated hyperbilirubinemia, which is rather congenital in origin. Conjugated are two, Dubin-Johnson and rotors, and unconjugated is Crigler-Najjar type 1, type 2, as well as the Gilbert syndrome. Now I have already discussed blackening color of the liver as shown in the image. You can just check here also. This is a laparoscopic image which was incidentally detected, and also the case was reported. The color of the liver is totally black. Black colored liver in histopathology signifies two things: hemochromatosis or either Dubin-Johnson syndrome, and if it is gross black, obviously this is nothing else other than Dubin-Johnson syndrome. Alright. So is biopsy very much essential for differentiating between Dubin-Johnson and rotor? Answer is no, absolutely not. There are biochemical parameters and lab tests which can help you to identify. Now these are usually harmless, condition does not lead to any significant mortality, so does not require even identification of the condition which lead to it. Alright. Now for Dubin-Johnson, you should know that for exam point of view, that question that is asked is which gene or transporter is defected. It is organic anion transporter defect, which is also known as multi-drug transporter defect. Alright. This transporter defect, because of which bile glucuronide conjugated bile cannot leak and leading to conjugated hyperbilirubinemia. Now due to the defect in this pathway, not only biliary channel is affected, as well as epinephrine metabolite does not get excreted and get accumulated in liver, which gives the black color. A lot of students multiple times confuse that black color is due to bile. No, it is not due to bile, it is mainly due to accumulation of epinephrine metabolites. Alright. Okay. So here you can see, here this is from again black colored in histopathology, as well as completely black colored liver seen in Dubin-Johnson. Now how to diagnose Dubin-Johnson biochemically? Biochemically you can diagnose with the help of urine coproporphyrin level. Usually urine coproporphyrin level is we take ratio of coproporphyrin 1 and 3. Alright. Now the ratio is less than 20%. It remains less than 20% in normal case, whereas it remains more than 80%. The abnormal one, 3 becomes more, 1 becomes more than 3 in case of Dubin-Johnson, and it is more than 80%. 1 is the abnormal form, it becomes more than 80% in case of Dubin-Johnson. Alright. Okay. So these are the initial set of questions, 10 questions. In the next video we will discuss other rest of the questions from the gastroenterology.